My name is Dr. Sarah Rutherford. I'm an associate professor of clinical medicine at Weill Cornell Medicine in New York. Follicular lymphoma treatment and management has evolved and is continuing to evolve rapidly over the past few years, and it's a really exciting area that I think is going to benefit and already is benefiting our patients. We were asked to participate in a series actually with the Blood Journal, in which there are going to be multiple articles on different topics related to follicular lymphoma. And I think in some ways our assignment has been one of the more exciting ones because we're really able to try to project to the future of follicular lymphoma and how we think that it will be managed in the coming years. We really focus in a number of important areas, and one of those is the evolution of treatment in the frontline setting. So many patients who are diagnosed with follicular lymphoma and meet indication for treatment are currently being treated with chemotherapy, such as bendamustine and rituximab, also with the monoclonal antibodies against CD20. We do worry about some toxicities associated with bendamustine and other chemotherapies. In the meantime, we've had FDA approvals of a really exciting category of drugs called bispecific antibodies that target CD20 and CD3 and basically help the immune system to better fight the lymphoma. So what we look forward to seeing is results of clinical trials that are ongoing in the frontline setting with these bispecific antibodies, which again currently are approved in the third line setting. And many of them are being studied in combination with other agents like tazemetostat or BTK inhibitors and lenalidomide. And we think that it is likely that that may replace chemotherapy-based treatment for patients in their first line of treatment in the future. In addition to the application of these newer type treatments, immunotherapy approaches in the frontline setting, we also really want there to be a focus on management of patients who progress early or who transform to an aggressive lymphoma. It has been well established by Dr. Carla Casulos and others in the field that patients who have what's called POD or POD24 who progress within 24 months of receiving first-line chemotherapy and rituximab-based therapy are those who have particularly poor outcomes. And so I think trying to be able to figure out who those patients are in advance as we learn more about biology. So if we were able to know in a newly diagnosed patient that they're more likely to be one of those that progresses early, then we would be able to treat them differently. A couple of other strategies that we talked about in our paper were the focus on quality of life. So at this point in time, follicular lymphoma is not viewed as a curable disease. I think that could change over time. We also touched on that topic. But because this is a disease that people tend to be treated for and then have long remissions and may require treatment later, and some people actually don't even require treatment at all, at least initially. This is really a disease where we need to focus on quality of life. And a key aspect that's being incorporated in clinical trials now is something called patient-reported outcomes, where patients are really able to let us know, let their doctors and their teams know exactly what their side effects are and what they're experiencing as they're going through their course. And I think that that's really key for us to incorporate, especially with these novel therapies, as we move forward, to really try to optimize them feeling as well as possible for as long as possible. And then finally, I want to mention that I think there will be novel monitoring techniques, particularly minimal residual disease testing. And what's I think the most exciting right now way of doing that is with a type of assay called circulating tumor DNA. There are a number of different companies that are using techniques to try to basically detect the level of lymphoma in the blood at the time of diagnosis, at the time during treatment, after treatment, and surveillance. And I think this will be key moving forward. So for example, I mentioned the bispecific antibodies earlier on in this discussion, and some of those are being given ongoing as long as patients are responding. And again, this is currently in the third or greater line setting. Whereas other ones are being stopped after a number of cycles and patients are being monitored closely. And so I think a great applicability of the ctDNA type testing will be for us to say, okay, this patient had detectable ctDNA at baseline, and now they've received 6 cycles of this bispecific antibody. We don't detect the ctDNA now. We can monitor them closely and hold off on further treatment. These type of treatments do have an impact on the immune system. They make patients more susceptible to infections. So even though they're very well tolerated, we do want to try to minimize the treatment over time to try to make sure that people are feeling well and not getting sick and having infections. So I think these different areas, just to summarize, the changing of treatment in the frontline setting with some of these newer type strategies, hopefully moving up to be used in newly diagnosed patients, figuring out how we can optimize the management in patients who progress early or transform to aggressive lymphomas, and ultimately being able to identify them before we even start treatment, focusing on the quality of life of patients and having endpoints in our clinical trials that really emphasize that. And then finally, using these monitoring techniques such as ctDNA to help guide our approach are all strategies that I foresee in my team. Dr. Erin Mulvey and Dr. John Leonard, we work together really conceiving this paper, and we're so excited for our patients more than anything else, because I think that they're going to continue to do better, tolerate treatment better, live longer, and live better as we move forward in the future.